Well, first of all, I'd like to thank the organizers of the meeting, and especially Professor Dr. Carlos Magno Fortaleza for inviting me to talk to you about One Health. Carlos is an old friend, so thank you again, Carlos. One Health is an interesting term. We have all heard about it, and it gives us a nice, warm, fuzzy feeling because it holds the promise of being able to solve some very, very complex health-related problems. However, it's also a very misunderstood term as well. And our university, my university, University of Saskatchewan in Canada, several years ago decided to make One Health an area of priority. In other words, they were willing to put resources into developing One Health as an important component of the university. And they asked me to guide the program, to guide the initiative. This, of course, was in addition to my regular duties, lecturing about infectious diseases, zoonotic diseases, and having a successful research program, and also all my administrative duties as well. But you know, it turned out that it was one of the most exciting things that I've done in my 45 years as a university professor. So let's see what One Health is all about. So the term One Medicine was first coined in the early 70s by Professor Calvin Schwabe. And it was because he thought that there was a great deal of similarity between veterinary medicine and human medicine. And if we could work together, if veterinarians and physicians could work together, we could probably solve some complex problems. So that was the whole idea of One Medicine. But then, you know, in the early 2000s, the first SARS pandemic came around, and very soon afterwards, we had the H5N1 pandemic. And so people started to recognize the importance of zoonotic diseases in the environment. And in 2003, there was a conference in New York. And as a result of the conference, the term One Health was coined, although I'm sure people have used that term before. And they came up with what has now been known as the Manhattan Principles, which sort of govern what One Health is all about. And you know, so now we've had One Health around for over 20 years, and an enormous amount of money has been spent on it. And so now there's a good time to ask the question, what have we actually achieved in the name of One Health? And so perhaps a better title for my talk would be One Health, Where Are We Now? And what I'll try to tell you why we haven't been as successful as we would like to be, or the potential that we have. And that is because we have embraced the slogan of One Health, rather than actually embracing the process that One Health actually is about. So what I'm going to do today is to talk to you a bit about what One Health is, and why, if we ignore the One Health approach, the actual way of working using One Health, we don't fulfill the promises. And then finally, I'm going to tell you about what we have done about it at the University of Saskatchewan. Perhaps, actually, I shouldn't say just the University of Saskatchewan, because we've had some very important partners at UNESCO in Brazil, in Germany, and India as well. So One Health, if you look at the CDC website, the Centers for Disease Control website, it recognizes One Health, and it recognizes that the health of animals and people are closely connected to the environment that we all live in. And if you can actually look at it in a much more simpler way, and that is that the health of the environment and all of those that live within it is intimately connected. Because we are animals, so I think we can sort of look at it that way. So what exactly is the environment? So if you were to Google environment, this is what you come up with. Environment, as most people recognize it, is the birds, the bees, and the trees. However, if you were to look at the environment in terms of what influences us, how it influences how we live, our health, and so on, the environment actually includes much more than the birds, the bees, and the trees. For instance, we have the historical environment. We are influenced by what came before us. We have the social environment. What happens around us influences how we see the world and how it affects our health. We have, of course, the economic environment. It depends on how much money we have, how much money is allocated to different resources to help influences as well. The political environment, the power structure, the people who have the power or the institutions that have power, how does that influences as well. And finally, the psychological environment is also really important. And so if you are thinking about the environment and how it influences and how the health of the environment is tied in with the health of the people and animals in it, I think you've got to think about the environment in a much, much broader sense. So when the term first came out, One Health, as I said, it seems like a very obvious thing. Of course, the health of the environment and people and animals is intimately related. I mean, it seems like a given. And it was such an obvious thing that all of a sudden the whole idea exploded. And all over the world, we now have, or we had organizations such as the One Health Congress, the One Health Network, the One Health Umbrella, the One Health Platform, you name it. We had all sorts of organizations that sprung up with the term One Health. And of course, governments bought into it as well. And so there was a lot of money put aside because it did actually hold the promise of trying to solve complex problems. But what did we do with that money? Well, most of what we did with that money was to go to meetings all over the world. In my opinion, I don't think in the 20 years that we have had the term One Health, and we've been practicing One Health, that we've been able to achieve the full potential of what we could have done. So why is that? So if you look at the definition that the CDC, the Centers of Disease Control, has, it actually has two parts. The first part, of course, the second part actually recognizes the connection, but if you look at the first part, it says quite clearly that One Health is a collaborative and multi-sectorial and transdisciplinary approach, working at the local, regional, national, and global levels. And I think this is what defines the One Health approach. It is not just simply important to recognize that everything is connected. It is really important to work in a very, very collaborative way to do this. And so let me tell you why that's important. So if you are looking at the health, let's say here we have a community and we're looking at the health of individuals in that community. Let's say we have systems in place to look after the health of individuals. Now, I fully recognize that there are huge inequities in how healthcare is delivered, and not everybody gets the same healthcare. But by the large, we have this covered. We have physicians who look after the health of individuals. We have veterinarians who look after the health of animals. We have diagnostic laboratories in place to help the physicians and veterinarians recognize what the problem is, to diagnose the problems. And then, of course, we have the healthcare system and pharmaceutical industry to help these individuals treat the sick individuals. So where the health of individuals is concerned, we've got it covered. However, if you now start looking at the health of communities, it becomes much, much more complex. Because health problems here may have a biological cause, like infectious diseases. We've all been living through SARS-2 or COVID-19. There are biological causes of this, but at the same time, there could be environmental causes for the problem, such as toxins in the environment, pollution, all sorts of things. There can be social causes. Often health issues have social causes that play a role in health as well. There could be economic causes. There could be political causes. There could be historical and cultural reasons. In Canada, for instance, we are recognizing that the problems that our Indigenous people have, to some extent, are because of historical reasons that have sort of put all of that into place. So you can have complex causes. Now, once you have understood what it is, then you can come up with solutions. And some of the solutions can be basic sciences or health-related. The scientists and virologists and bacteriologists can figure out what's going on. Epidemiologists can figure out what's going on. And then you can have engineering solutions as well, providing clean drinking water, for instance. Once you come up with these solutions, however, you still have to implement them. And to be able to implement them, you need a communication strategy. You need to be able to frame your solutions so that the policymakers can understand them, and also the people who are involved can understand them. Sometimes framing that is not a simple thing. And then finally, you have to motivate the people to be able so that your solutions can be implemented. And once you've implemented solutions, you can have unexpected consequences of your solutions. And so in order to understand complex health-related problems, you need everybody at the table. You need people from different disciplines looking at the problem, trying to understand it. And once you've understood the problem and come up with solutions, you need different people, perhaps, to help you implement these things, to convince the government, let's say, on how to come up with policies. And then you also need to know how the solutions that you've implemented are going to cause or affect what's going on. And so the moral of the story is that if you want to use the One Health approach to try to solve complex problems, you have to have everyone at the table working together. And that's what I think has happened. We have embraced the whole idea of One Health. I think it's great, but we've been very reluctant to actually implement the use of the One Health approach. In other words, the collaborative approach. Now, why is this? One of the reasons for this, at least I think, lies in our brain. And a few months ago, I read a book by Ian McGilchrist. He's a psychiatrist. And he's got a book called The Master and His Emissary. And it's a thick book. It's a fascinating book. And what he does is that he goes back and he collates, he catalogs all the information that's there to try to understand why we have two brains, why we have a left brain and a right brain. And a lot of the data that comes from patients who have had strokes in one side of their cerebral hemispheres, or the other, and what sort of do they lose and what do they gain when that happens. It's a fascinating book. And if you look at the book and try to sort of summarize it in one slide, it tells us that we have two sides of the brain. And although they do the same things, they look at the world in a very, very different way. For instance, the left side of our brain is very important. It is it's very rational. It looks for solutions, finds solutions. It's very efficient. It's very focused. But at the same time, there are some problems with the left side of our brain. And that is that while it's very efficient, it has the tendency to reduce the problems to more manageable ways. The other problem with the left side of our brain, according to McGilchrist, is that once it's found a solution, once it thinks it has found a solution to a problem, it is very reluctant to actually entertain any other points of view. Okay? It also makes lots of assumptions. the right side of the left side, by the way, is very important. In fact, there was a lecture I heard about that said, the left side of your brain, don't leave home without it. And that's kind of important, because this is important. The right side of our brain, on the other hand, is more contextual. It is more likely to look at the big picture. It is more likely to try to consider other points of view. But on the other hand, it takes its time to do this. Now, in order to be able to not just understand One Health, but to use the One Health approach, what you have to do is to couple the left and right side of your brain. And that's what has been the most difficult, because all of us have been trained to use the left side of our brain because it is just so efficient. And we reward the use of the left side of our brain all the time we're in school, all the time we're in school, in university, in medical colleges and veterinary colleges, in research. We reward the left side of our brain and try to ignore the right side of our brain. So a veterinarian, a physician, a biologist, and a scientist and a policy expert walk into a bar. Now, for those of you who are familiar with sort of North American English, British culture, this is how a lot of jokes start. They usually start a rabbi, a priest, a mullah, and a pundit walk into a bar, and then the joke happens. This actually did happen. It was the year 2012, and several of us were in Berlin for a meeting, and also we had some friends in Berlin, and we all went to a bar, and we were enjoying our beer and talking about various things. And while we were doing that, the topic of our students came up. And you know, as a group, we usually disagree with each other about just about everything. But there's one thing that we agreed on, and that is that our students, the students who graduate from our laboratories, the residents who graduate or finish residencies in our clinics, and so on, they're amazingly people. They're very bright. They're very good at what they do. The problem is that we don't train them to collaborate. We don't train them to collaborate with other fields. We don't train them to look at the big picture. My students can look at infectious diseases. They can look at a particular pathway in bats that controls viral infection, but they have trouble trying to sort of take this and figure out where it fits into the great scheme of things. So, you know, normally what happens is when you go to a bar and you have a drink, everything that you say in the bar stays in the bar. But in this case, what we decided to do was to do something about it. So what we did was we applied to a granting agency in Canada called National Sciences and Engineering Research Council. And they had a program that would fund something like that. So we proposed to them that we would come up with a program that, well, a One Health program, for instance. And we called it Integrated Training Program in Infectious Diseases, Food Safety, and Public Policy. We talked about policy was interesting. It's kind of a mouthful, and so we shortened it to ITRAP. Oops. So, we were successful. They gave us a fair amount of money, and at the same time, the university also helped us financially by dedicating a number of scholarships to this thing, and our partners in industry also provided funding. So we had the most important thing that you need to have a successful program, and that is money. And so that was fantastic. And it wasn't just us. We had partner universities in Germany, the Free University in Germany, a partner university in India, and of course UNESCO was an important partner in all of this. So our goals were fairly simple. What we wanted to do was to bring together the next generation of policy and decision makers and give them the opportunity to work cooperatively to analyze current One Health problems and suggest solutions that could be implemented. Now, the problem, though, was none of us who had actually got the grant, the investigators, if you might want to call them, had the faintest idea how we were going to go about doing this. How are we going to get students to get their left brain and right brain to collaborate? Because after all, we were the problem. We'd been trained to use our left brain, and our students, of course, were in some ways images of what we were. So we were the problem. So how do you go about changing that? So what we came up with a great idea. Well, why don't we make this student-centered? Because even though we're set in our ways, we have gray hair and we have our set ideas, when students come to us, when they're new students, they're perhaps less brainwashed than we are. And so what we decided to do was to, we made the program student-centered. The other thing we had to decide was, do we have a degree program? Should we have a program where at the end of 2 years you get a master's degree, or at the end of 4 years you get a PhD? And we decided not to do that. And the reason for that is that if we had, at the end of that, if the students got a degree in One Health, then we would have students that have a great deal of breadth, but very little depth. And so these students, once they graduated, would be great bureaucrats, but there wouldn't be much use other than that. And so we decided not to have a degree program, but instead recruit students who were already in master's or PhD programs, and that would give them the depth. And we recruited students from just about every program that you could think of, everything from English literature to microbiology, to political science, to engineering, to law, to policy, you name it. We recruit students from every possible field we could think of. We also made the thing also very diverse in terms of internationally. So we recruited students from all over the world. We tried to make our recruits as multicultural as we could, so they could bring different perspectives to the table. We also made it diverse by making it multilingual. So we recruited students from all over the world. Now, the fact that we had funding helped a great deal, because obviously if I go to a scientist or professor at the University of Saskatchewan or Bonacaru or anywhere else and say, okay, could you release your student to take part in the program? Their answer would be, no, of course not. It would take them away from their research. So what we were able to do was say, okay, if you allow your student to spend some time in this program over the next year, we can provide your student with a stipend for 1 or 2 years. And that was the big carrot that we used. So at the center of the program was small group discussions. What we did was we made these groups as diverse as possible. We had anything from about 6 to 8 students per group. They were international, and we did all of this using the internet. The students met twice a week in class, and then they also communicated with each other as well. And we gave the students, each group, a different, complex, real One Health problem. And then we gave them 2 months to solve the problem on their own. Each group had a facilitator, a professor, but the job of the professor was not to provide them with any kind of information. It was just to guide the group. At the end of the 2 months, they were supposed to present their analysis to the rest of the class, but at the same time, they were supposed to write up their analysis and solutions and in a publishable form and submit them for publication in a peer-reviewed journal as well. Now, when the students first started in this group, they hated it. They absolutely hated it, because all through their lives, they'd gone to an educational system where somebody stood in front of them and told them what they should know, and they would memorize that and try to use it. And here we were saying, okay, the experts were not going to tell you anything. Here you are. You figure it out. But very soon they realized that if there was a health problem somewhere in the tribal areas of India, the physician the physician among them could understand that, but in order to figure out why that problem occurred in the first place, how to solve it, and how to implement their solutions, they would need the help of everybody else in the group. They would need the person from policy, they would need the person from communication, and so on. So this is where we're amazingly well. The other thing that we had our students do, and again, the funding made it possible, we expected each student to spend between 1 month to 6 weeks at an international organization where they could see what they had learned, see it in action. For instance, the World Health Organization in Geneva, the Food and Agriculture Organization in Rome, the Centers for Disease Control in Atlanta, Georgia, and a number of other places. And the WHO in particular really liked our students. They would come and they already knew how to collaborate. They already knew how to be in a group of people and look for compromises without sort of compromising, if you will, their ultimate goals. So they knew how to do that. So they attached our students to decision-making bodies. So this is the second thing the students had to do. Finally, what the students had to do was to, we held summer schools or workshops. Well, of course, summer in the Northern Hemisphere was winter in Brazil. We held them in Germany, India, and Brazil, where we took some of our students, about 10 of our students, and when we got to our host institutions, they had anything from about 50 to 100 other students from that country at that workshop. And we did the same thing. We divided them up into groups, there we are. Okay, yeah, summer school. So we divided them up into groups where we'd have one student and the rest of the students from the host country, and give them some problems to solve, much the same way. Only problem was that they only had a week to do this, rather than 2 months to do this, and it all sorts of problems. Of course, one of the problems was language. One of the problems was language. Our students didn't know any Portuguese, German, or Hindi, or Punjabi. The students in host countries often, sometimes weren't fluent in English either. But it was amazing. The students were able to find solutions to that problem, to the problem of language very easily. I'll give you an example. We had one session in 2017 in Botucatu. The person who was absolutely responsible for having us there was Professor Jane Majid. So with that, we had lots of students. We had students from all over Brazil. We had faculty from all over Brazil as well. We have anthropologists, we had infectious disease people, we had a communication expert from Canada, and we did the same thing. And just to give an example of what kind of things they looked at, on the left we have Arctic food security and wildlife health, bat rabies in people and livestock in Brazil, cancer train. There's a really interesting train that goes from Punjab, the state of Punjab in India, to the state of Rajasthan. It is almost completely filled with cancer patients who go from Punjab to a hospital in Rajasthan for treatment. And there were a whole bunch of other ones. And what we did was we gave each group a newspaper story. Instead of telling them what to do, we just gave them a newspaper story that illustrated the problem, and then gave them a week to figure it out. Now, language, again, was they solved the problem because in each group there was at least 1 or 2 people who could speak both languages, English and Portuguese. And something really interesting happened. I noticed that in one of the presentations at the end, the group had a presentation, and the slides were either in English or in Portuguese. If the slide was in English, the person presenting the text was presented in Portuguese. The next slide would then be in Portuguese, and the student would present that in English. And so they solved the problem of trying to communicate. It was absolutely really fabulous. So it's a very successful program. We unfortunately it came to an end in 2018. The recession hit, and we've been trying to find funding to try to continue it in different ways. And we've had some problem with that. But just to give you an example, in those 6 years that we had it, we had students. You can see the list over here, from 12 different countries in 18 different universities. So we had students from Canada, Germany, Brazil, France, Italy, India, 2 universities in India, South Africa, Uganda, Australia, Ethiopia, Sweden, Switzerland, the UK, and Thailand. So we had students in our program from all of these places. And you might imagine, how do you do this, even do this electronically? And that presented problems because the time zones, okay? So if it's early morning in Saskatoon, it's late afternoon in Europe, or afternoon in Europe, it's late afternoon in East Africa, it's night in India, and it's the next morning in Australia. But you know, our students were really motivated. They were able to do this. Okay, so we're getting towards the end of my presentation, and what I'd like to do is to kind of summarize for you what the One Health approach is. The One Health approach requires the people doing One Health to have 2 really important attributes, if you will. First one is humility. The humility to know that your field of expertise may not have all the answers. The second attribute you must have is one of respect. You have to be able to respect and realize that even though your field might not have the answer, other fields might. And so you need to have respect for that. So in order to have the One Health approach, and I think this is an area why we have failed to actually fulfill the complete promise of One Health, is we've lacked in doing this, realizing that we need humility and respect to that. So finally, what I'm going to do is we're now back to that same question. One Health, what now? And you know, what I'd like you to do is, can you think of a problem, a global problem, a local problem, any big health-related problem that may be solved by using the One Health approach? So I'd like you to think about that. And while we're open to any questions that you might have, but while we're doing that, think about the problem. If you've got some time, we can talk about that. But if you can think about a problem, well, do something about it. So thank you very much.
Thank you, Vikram.